Welcome to the School of Medicine at Case Western Reserve University. For you in the audience, I'm George Kikano. I'm Vice Dean for Community Health here. I'm also Director of the newly established Weatherhead Institute for Family Medicine and Community Health. Like some of you here, I'm a physician by training. I'm by no means a data expert or a technology expert in here. What I'm finding, like in my practice these days, I'm using more and more technology. I get bombarded with data, don't know what to do with it. Please don't talk to my legal department at the hospital. I text, I email, I FaceTime with patients, whether they're here or everywhere. The other thing I'm seeing, get lots of data from payers. I get like third-party data, I get Medicaid data. I'm bombarded with QIOs, name it, quality assurance outcome. I have no idea what to do with it. I get these files with patients I haven't seen. This is their A1C, this is their blood pressure. It goes in the recycle bin. I don't trust it. I don't know what to do with it. I sit in the hospital. There's so much on somewhere in the clouds about patients I'm taking care of. I'm a family. Sorry, Ronnie. I don't know what to do with your data when I get it. So, what's my hope for this? This is the first symposium actually. Shiran Krikorian, who's from the Department of Epi. This is Shiran's brain idea about the symposium. I think this will be an exciting opportunity to get the public sectors, researchers, academicians, people, physicians together to start a discussion about data stewardship, data management, what to do with it, and something that's meaningful that's going to help patients and communities. For today, we lots of debate on the planning committee. What shall we select? There's so much to talk about. What are the priorities? So what we did, we used the 5 priorities identified by the State of Ohio Improvement Program. The state came up with 5 priorities. I said we're going to take the first 3 of them. We're going to take chronic diseases, infant mortality and preterm birth, mental health and addiction, just to start a discussion and dialogue in here. It's my hope that we all, as we collect our data and centers of excellence, our things get dumped through hospital, outpatients, EHR, or other data. We can bring pieces together for meaningful use, ultimately to drive programs, prioritize, with limited resources, what do we invest in? Policy would be a key thing for this. How can we work? Academicians, researchers, with the public sector to drive policy that's going to make meaningful use. Ultimately, it's a lower cost, better quality, and better health for the communities here. Really, I'm looking forward for our 3 panels from this morning. Please hold your question to the end of each panelist. And sometime in the afternoon, we're going to have an open forum. So please, any questions you have, there's going to be lots of time for open discussion at the end of the day. So I'm looking forward for your insights in here and for the panelists. At this point, it's my distinct pleasure to introduce my boss and our dean, Dr. Pam Davis. Pam is the real threat in academic medicine. Dr. Davis has a MD, PhD in both physiology and pharmacology from Duke. She's an internationally renowned researcher in cystic fibrosis, as you know, outstanding teacher, has many awards. And for the past 6 years, she's taken what she learned in the basic science lab to really care about the communities. If you heard, we just got the 2nd renewal of our CTSA NIH-funded grant for $65 million. The objective is to do meaningful research in the community. And I believe Dr. Davis is the only dean in the country who's also a PI on CTSA grants. So she's a real thread between basic science research and community research. So Dr. Davis, it's yours.
Thank you. Well, thank you, George, for that kind introduction. Good morning to all of you, and thank you for joining us. I think this is going to be a very rewarding day. The famed innovator Steve Jobs once said, "A lot of people in our industry haven't had very diverse experiences, so they don't have enough dots to connect. They end up with very linear solutions without a broad perspective on the problem. The broader one's understanding of the human experience, the better design we will have." Connecting the dots to come up with innovative solutions is what we're all about here today. Our purpose in convening this group in health data integration and stewardship and discussing the role of Case Western Reserve University and other research institutions in partnering to determine how we can best share and connect to the data, apply this data safely and efficiently, and use this technology in ways that advance patient health and create cost savings. So we have a fairly lofty objective for the meeting this morning. And all of you here in this room bring perspectives and experience and expertise, as well as experience from academia, healthcare, medical science, information technology, community advocacy, public service, and more. Through this symposium, we hope to find innovative ways to remove barriers and connect the dots between technology, research, and healthcare. Because when we connect these dots, we have an opportunity both to transform healthcare and to improve the lives of our patients and in our communities. Last April, we held a similar symposium at the School of Medicine on health informatics, and we discussed big data. I'm still stunned when I think about how big it really is. Every day, 2.5 quintillion bytes of data are created. A quintillion is one with 18 zeros after it. And 90% of the data in the world has been created in the last 2 years. We are getting buried in data. But we now have the challenge to turn that into something important and meaningful. I want to give you a few examples. When I knew I was hooked on big data was when I heard about David Kalber's study that made the front page of the Plain Dealer this morning. Using Explorus, which is a startup company spun out of the Cleveland Clinic, this technology, he worked on a very interesting problem. Explorus is a technology that de-identifies electronic health records so that we can conduct research on real patients without compromising privacy or having detailed IRB approvals. Dr. Kalber replicated a Scandinavian study on blood clots that took some 18 years to compile in only 2 months from idea to submission, while increasing the patient's sample size 40-fold. Wow, that's utilizing big data. Came to exactly the same conclusions. It took nearly 2 decades in the field. My second example comes from GQ Zhang, who is a co-director of the BRIM Core in the CTSA and the inventor of PhysioMimi. Our vision for the round of funding in the CTSA is to enhance community health through research infrastructure, and we must harness big data in order to do that. Within the CTSC, we have many exciting developments emerging through an array of informatics tools. They are leading edge, ontology-driven, and they have been or are being deployed nationwide, and they are created to solve real information management problems. And they are tools at our researchers' disposal to use right now. PhysioMimi technology, created by GQ Zhang's group in collaboration with clinical researchers, is a wonderful model of teamwork that started at CWRU and then evolved into a true partnership between informaticians and clinical researchers. PhysioMimi is an informatics infrastructure for collecting, managing, and analyzing diverse data types across institutions that were collected in different formats. This is a technology that can literally help us connect the dots. And finally, I want to talk a little bit about the Governor's Medical Corridor Challenge. Case Western Reserve has been partnering across the state of Ohio with other CTSAs in Columbus and Cincinnati to advance biomedical research informatics. Phil Payne at Ohio State University leads the informatics component of this statewide collaboration, and we anticipate developing enhanced capabilities and access to populations and data through this partnership to increase research funding in Ohio, reduce statewide healthcare expenditures, and lead to quality improvement and comparative effectiveness research. These are very exciting times. So much is already underway, and I hope this meeting will help us all connect the dots and use healthcare data to drive innovative programs and advance human health in Ohio and beyond. I look at the symposium today really as a starting point, the beginning of many more conversations needed to create the collaborative environment. I hope this is the first of many symposia where we can come together and discuss challenges and opportunities represented in our data. And I thank each and every one of you for contributing your perspectives and being with us today. It is now my pleasure to introduce our next speaker, who is Rex Plauck. Rex has extensive management experience in both the private sector and state government. He has managed numerous strategic initiatives for large companies and has run several early startup companies himself. He has previously been the Deputy CIO for the state of Ohio, and he was the state's first enterprise health IT officer. He developed and funded the Ohio Health Information Partnership. He is currently working with the Governor's Office of Health Transformation. He is responsible for managing numerous strategic initiatives, including implementing an integrated eligibility system, developing an enterprise health and human services business intelligence capability, and preparing for health insurance exchange. We welcome to our podium right now Rex Plauck.
I want to thank Dean Davis and her staff for inviting me to come and speak to you all. It's really amazing to see the interactions and the connection points between the goals of the symposium and where the Governor's Office of Health Transformation are driving, where we're focused. And I see a lot of opportunity to partner and drive towards common goals. It's been really exciting to see this initiative come together. So I want to kind of talk about some of the initiatives we have underway. But before I do that, I want to put it into a perspective. So I want to kind of give you the overall vision of the Office of Health Transformation, because as the Dean talked about, massive amount of data, and we like to kind of talk about it being information and not data. So the concept is turning that all into something that's useful versus just a bunch of data that we can't really make use of. And so we talked briefly before we all came in here, and we were talking about what do you really do with all this data and where do you start with it? And so our focus is what are the specific policy initiatives and outcomes we're looking for, and then start with the data and the information that will drive us in those directions. And so that's why it's important to kind of step back and give you the overview. OHT has kind of a three-phase strategy, and the first phase was around modernizing Medicaid in the state of Ohio. And John Corlett knows the challenges with that. It's a diverse program, $20 billion spread out over 6 agencies, and it was buried inside another state agency. And so what the administration did initially was focus on how do we pull the funding out of all those agencies and get it consolidated in one area. We recently announced that we're going to elevate Medicaid to its own agency in a cabinet level position. John's kind of wishing he did that sooner, so that it really has the authority and the resources to kind of direct its own outcomes. And so there were a number of initiatives along those lines. And so the focus on modernizing Medicaid was kind of the first year, and those initiatives are well underway. Some are done, some are long-term, some are never done. They're ongoing. And then the OHT, and that acronym, Office of Health Transformation, so I'll use OHT, then turned its attention to what we're calling streamlining state government and the HHS components of it. So as I talked about, there was 6 to 10 agencies that all have some connection points, and those are just the straight up health and human services agencies. Doesn't really even include corrections and youth facilities, who are really kind of a big component of delivering care to the citizens of Ohio. And so those folks have been kind of brought into the fold, and we're kind of in the focus right now really of really driving these streamlining initiatives. And some of these things that I'm going to talk about in a few minutes about a single integrated eligibility system that's a new modern system. The state has a current eligibility system that is 30 plus years old and really it does not function very well. We're talking about integrated business intelligence and things like that. So I'll talk about those a little bit in more depth here in a few minutes. And right now, where the leadership team in OHT is really starting to focus at this very moment is what we're calling payment transformation. And that's really the goal and the outcome from our perspective of where we need to drive. And that's like paying for outcomes, not just paying fee for service, paying for activity, but actually paying for improved health outcomes for patients. And that's really the goal. We thought we had to address Medicaid modernization and the streamlining to actually put ourselves in a position to be successful at payment transformation. We couldn't just jump from where we were to that perspective. So we're on that, we're beginning the planning on that phase as we move into the next biennial budget process. We're thinking ahead about what resources we'll need to do those sort of activities. And again, I'll talk about some of those things as well. But that's the broad vision, the kind of big categories of work within the Office of Health Transformation. There's some specific items there are some items that probably many of you here probably don't care, but there are some items that are very kind of, I think, very specifically related to the symposium and initiatives that you're all looking at and going to discuss today. Patient-centered medical homes. For patient-centered medical homes to really be successful, we need to get the information into the physician's hands, the right information at the right time. And that's all part of what I think you'll be talking about here today. Another component, and Dean Davis talked about this a bit, and that was, I don't like to say coordinating, but integrating mental health and physical health services together. And so that is a critical component of the administration's, and again, that means pulling that data together, both from the behavioral health component as well as the physical health and treating it in a holistic sense. I talked a bit about payment for outcomes. We can't pay for outcomes if we don't have the data to support it. Otherwise, we would just be sending money out the door for things that may have never happened. And so we have to have data and information to drive payment for outcomes. And that includes baselining where folks are so that we can see and monitor and measure the performance of their health care and then paying for that change. And that is, as you probably all know, not a trivial task. And then lastly, this is an item that we've just begun in the last couple of weeks, is the administration is getting ready to apply for a state innovation grant around payment transformation. And in particular, we're going to focus on patient-centered medical homes, which is really being driven from the Ohio Department of Health. There's a number of folks here that have been critical, I think Bob, in driving the symposium here. And those folks are really the leaders within the administration for the patient-centered medical homes. And then also for episodes of care. And again, kind of looking for care that crosses settings and how do we pay for that as a single episode versus individual steps along the way for that type of care. And those are kind of two of the areas where we're going to really focus on. When we look at that, and pretty soon if any of you know Greg Moody, there's always a one-pager that's a picture. And when you see that, which will be coming out pretty soon, you'll see enablers. And the enablers are health information exchanges, EMRs, business intelligence tools, all of those sort of things that you're starting to focus on today. And so you can start to see those integration points as Dean Davis was talking about before I came up here, of where we're driving, where we want to be, and where you all are starting to look at. And clearly partnering with the academic institutions and the thought leaders in the state is critical for us. This administration has been very clear that this is an economic engine for the state and an intellectual engine for the state of Ohio, and seeing this partnership is going to be very important for us. So along those lines, I'm going to just talk about a few of our initiatives that are underway or about to be underway that might be relevant to today's conversation. One is we've recently, just a couple weeks ago, released an RFP for an integrated eligibility system which is probably somewhat related to what you're doing here. But embedded in that RFP is the capability for us to also build the infrastructure for Health and Human Services business intelligence capability. As you might imagine, the amount of healthcare and health and human services data that we have spread across multiple agencies. We not just have silos of agencies, we have silos within agencies. And so for us to be able to say, how do we look across that? How do we look at somebody's care when they are potentially been in and out of prison, when they have mental health services and food stamps and TANF services? We can't see that way today. We see them as silos, but if we can look at this in a person-centric or a family-centric concept, then we think that we can drive a lot of benefits, both for health outcomes, as well as if you want to start to look at ancillary things like fraud detection. If you're a provider or a citizen that's doing fraud in Medicaid, you're probably doing it in food stamps and anywhere else. And so this kind of horizontal person, family-centric view is critical to where we want to drive this. And so in this RFP is the capability to build that infrastructure. Now, as probably most of you know in this room, and I'm sure Dean Davis knows this, is the technology is the easy part there. It's getting the people and the skill sets to actually use the data and figure out what's happening and how do we improve that. That's really the critical component of this. And so that is another item that we're beginning to contemplate is how do we build a team or teams of people to use this capability once it's in place. And we are looking at other kind of what we're calling quick hits, because clearly to do integrated business intelligence across state government is a long haul. We are immature in our current state, and we're going to have to go through a maturation process. We're going to have to go through things like master data management, and I'm not going to bore you through all the laborious steps, but they're foundational that we can't, without doing them, we won't be successful long term, but we're not content to sit and wait for 2 years or 3 years until that's all done. And so we're looking for quick hits. We're looking to partner with folks, and whether it's folks like you folks and the work that you all have going on here, if it's partnering with folks like Explores or other tools and people that have capabilities that would let us right now start to get quick hits and have wins, that's really important to us, and we'll be looking for those opportunities and have already started that process. Along those same lines, we have a tool internally primarily used around Medicaid called Decision Support System. And it's basically a data warehouse that pulls in all the Medicaid claims data, financial data, survey data, a variety of disparate data into a single database that Medicaid, many of the agencies, the attorney generals, state auditors, a number of folks use. Probably a lot of you folks who do data requests from the state, from Medicaid, those data requests end up going to this group. We just went through a process, and we're going to be radically increasing the capability of that DSS, both technologically wise, moving to a bigger, more powerful database, but more modern software. It's on a very old version, a particular tool. And so we are in the process of, in fiscal year 13, we'll have that migrated to a new platform to really increase our capabilities there. Another area that we've focused on is enabling health information exchanges in the state of Ohio. For those of you that follow state budget activity, there was recently a mid-biennial review, which was kind of a mini budget process. And in that, we put in a number of mechanisms to address privacy issues relative to healthcare data and how healthcare data is shared within the state of Ohio between healthcare providers. Some of those, I don't know if there are any attorneys in the room. All right, good. There's been a long kind of argument in Ohio about whether you're an opt-in or opt-out state relative to sharing information, and folks in different regions, folks in different facilities have different interpretations, and we felt that that really held us back. So we implemented language in the MBR that did a couple things. We said, state, regardless of anything that's in state law right now, HIPAA is our guiding principle. And so if you're meeting HIPAA criteria, you're meeting state criteria. And then we put in a couple of measures that said if you follow these measures, then we function inside of a opt-out mode for sharing healthcare data. And you still have to meet all the HIPAA criteria on that sharing it, but we're trying to make it clear that it's good to share this data electronically, and we want to facilitate that. So that was something else that we took care of very recently. I talked about the analytics team. We're in discussions right now with folks about how do we build analytic capacity. And there's really kind of two components of that, right? Part of it is why build and buy something that already exists. And so I saw a number of folks, met a number of folks before coming in here about where can we partner with the folks in this room to get some of that capacity, right? For that to probably work, we need to be able to share data better so it gets to this infrastructure capability and the data and the tools we talked about. So we're going to be looking for those capabilities, but we also understand we can't buy and we can't outsource all of that capability. And so we're looking at how do we build analytic capacity internally that we can use and that we can also partner with external folks. And again, we're pretty mature in this area, and so we're reaching out to experts to say, help us figure out how to build this. What should a team look like? How should it be structured? Where does it reside? Those sort of things. But we intend to stand up that kind of capability, and again, want to partner with folks like you in this room to figure out how to do that best, both so that we're successful internally and so that we can partner with all of you. And then lastly, is something I'd just like to share. It sounds kind of innocuous to those who have never been inside state government, but for those of you that have been there, this is huge. And we implemented in this mid-biennial review some language that we kind of call, from a Skunk Works perspective, agency without walls. And for those of you that have tried to be inside an agency and share data or people or money with another agency, contracts and legal processes and, literally years to just share kind of what could be kind of just mundane data. Again, going back to those silos. So what we've implemented is agencies without walls, which basically says in state law, if there is an initiative that is OHT supported, it's an OHT initiative, no contracts required, no interagency agreements required. We've got a simple, what we call operating protocol. We put it in place. We will post that operating protocol on our website, completely transparent to the public, but that in a matter of days and weeks, you can be up and running, you can be sharing data, money, people, any kind of resources that we need. And that's breaking down these walls and starting to really work collaboratively within state government and then put us in a better position to be able to work with all of you folks. Because I suspect if you're doing research or you're trying to do some initiative and you need data from multiple agencies, that means you're fighting through 2, 3, 4 bureaucracies. In this environment, you can find the agency that is your best partner, and through Agency Without Walls, they can break down those barriers for you. So we really see this as a critical initiative to move faster and be more efficient.